Thank you to the technical team. I think it's 8:49 already, and we can already start our module H today. So Assalamualaikum and a very good morning to everyone. So today we will be going through module H. So this is a very exciting module where we will showcase scientific papers which were submitted to the 24th Medical and Health Research Week. So I am Dr. Mawada Azman. I'm from Department of ENT, and today I'll serve as your moderator. So there will be 10 papers competing today, and these papers were shortlisted from a total of 34 abstracts that were submitted to the committee from the 1st June to the 30th July 2022. So all the presenters will spend about 13 minutes. So the first 8 minutes, we will display the pre-recorded video for poster presentation. So bear in mind, the pre-recorded video of poster presentation was up to the presenters' creativity altogether. So if the judges feel that the clarity is compromised by the restrictions of your screen display, you can always refer to the poster compilation, which is already sent to you in PDF form. So after the 8 minutes of pre-recorded video poster presentation, it will be followed by another 5 minutes of answering questions from our panel of judges. So at the end of 4 minutes, there will be a bell rung, and then at the end of 5 minutes, we'll put up a buzzer saying that the 5 minutes question and answer session is already completed for that particular paper. So before we start, let me introduce the judges. Can I have Kaidir display the biography of our judges? So our first judge for today is Datuk Dr. Sabarul Arfian bin Mokhtar. Datuk Dr. Sabarul Arfian bin Mokhtar is a consultant and professor of spine surgery and also head of Department of Orthopedic and Traumatology of Universiti Kebangsaan Malaysia. So Prof. Sabarul completed his PhD from Macquarie University in the year 2013, and his research interest is on degenerative diseases of the bone and novel biomaterial applications. So Professor Sabarul served as a Deputy Dean and Deputy Director of Development for Pusat Perubatan Universiti Kebangsaan Malaysia or UKMMC in 2017. So Prof. Sabarul is here. Prof, can you on your video, Prof?
It's on. I'm using two screens.
Oh my. So maybe I can.
Department screen doesn't have a video.
All right. So maybe I can let the secretariat. Can you please pin the different device that Prof. Sabarul is using?
Yeah, the other device I am using to look at the presentation.
Okay, Prof. Sabarul, cool.
So this is video and audio. My iPad.
Yeah. So I'll pin another one. So yeah, that is you. So we've got you pinned out already, Prof.
Yes.
All right. So our second judge, can we have the biography for the second judge? Yeah, Prof. Aniza, I can see you there. Hello. So our second judge is Associate Professor of Otorhinolaryngology. She's the sweet professor there, Prof. Aniza Khairia Wan Hamizan. So don't take her for granted. And she appears sweet, and she can be very in poster and research presentations, and she can be quite a figure. So she completed PhD in University of New South Wales, Sydney in 2018. So her area of research is in local allergic rhinitis and inflammation of the paranasal sinuses. So she's currently the deputy head of the Department of ORLHNS and practicing as a rhinologist. So with that, I think we've got all of our judges introduced. So we are ready to start the competition. If there's no questions from the judge, Prof. Sabarul and Prof. Aniza, are we ready?
Sure.
Yay, that's good. Okay, so we're going to start with the first paper presentation. So I'm going to invite the secretariat to display the video for abstract C4. The presenter will be Dr. Muhammad Azwan bin Ahmad. So he will be presenting on his research topic, the effects of self-management program as adjunctive to usual rehabilitation exercise on pain and functional outcomes for patients with knee osteoarthritis. And this is a randomized controlled trial. So can we have the video?
Assalamualaikum and good morning everyone. My name is Muhammad Azwan and today I will present my study and the title is The Effects of Self-Management Program as Adjunctive to Usual Rehabilitation Exercise on Pain and Functional Outcomes for Patients with Knee Osteoarthritis. For the introduction, knee osteoarthritis is a degenerative joint disease of the knee. It is increasing in the incidence and prevalence. Knee OA is commonly characterized by knee pain, limited knee movement, joint stiffness, muscle weakness, and functional mobility impairments. Without proper management, knee OA could lead to permanent disabilities associated with deterioration in physical and mental health. Self-management interventions such as home-based exercise and patient education have been shown as beneficial addition to usual physiotherapy care in the management of NEOA. However, home-based exercise and patient education are commonly prescribed separately as adjunct treatments and therefore limited is known about the effects of these treatments when combined. The study objective is to examine the effects of a structured home-based combined home-based exercise and patient education program as an adjunct to usual NEOA rehabilitation on pain score, functional mobility, and disability level. The study is a single-blinded assessor randomized control trial. The inclusion criteria were adults age 45 years old and above with symptomatic NEOA, clinical or radiographic diagnosis based on the American College of Rheumatology criteria, and able to walk independently for at least 3 meters. The required sample size was calculated using the G-Power statistical analysis software, with consideration of a 25% dropout. A total of 30 participants, which is 15 per group, was determined. In this study, 30 adults with NEOA were randomly allocated into experimental and control group using a computerized random allocation sequence through stratified randomization based on age and body mass index. Participants in both groups received their usual physiotherapy care weekly for 8 weeks. The usual physiotherapy treatment was prescribed and progressed tailored to the individual participants' needs based on recommended NEOA treatment guidelines. The usual physiotherapy treatment consisted of physical modalities and therapeutic exercise, for example, manual therapy techniques and strengthening exercises. The treatment was administered by qualified physiotherapists who were blinded towards the group allocation of the participants. Participants in the experimental group received a combination of home-based exercise and patient education program in addition to their usual physiotherapy care. The home-based exercise is in a form of booklet, was designed by adapting the contents from evidence-based treatment guidelines and relevant NEOA-related studies. The home-based exercise booklet comprised general information on NEOA, exercise training guidelines, and exercise diary. The home-based exercise was delivered in written and illustrated step-by-step image that consisted of mobilizing, stretching, strengthening, and functional exercises. Participants in the experimental group were instructed to perform the home-based exercise at least 4 times a week. Meanwhile, education was delivered through a group session. This patient education session was provided once in the first week of the intervention by one of the researchers. The patient education was based on the home-based exercise booklet, which covers NEOA self-management strategies and the importance of exercise. Meantime, to equalize treatment time between the two groups, participants in the control were instructed to perform daily simple home stretching exercises such as standing quadricep stretch, long sitting calf stretch, and supine hamstring stretch. Additionally, all participants were provided with a training diary and contacted by telephone for once every 2 weeks to remind them to continue performing home exercises as instructed. For the outcomes, the knee injury and osteoarthritis outcomes score, whose visual analog scale for pain and time up and go for mobility were measured pre-post intervention. All assessments were carried out by the same assessor who was blinded to the group allocations. Data were analyzed using SPSS by two-way ANOVA design with repeated measure to examine the interaction between groups and the time. The Banforone comparison test was performed to determine pairwise difference, the mean difference, and the 95% confidence interval. At baseline, between the two groups, no significant difference in participant demographic variables and no significant difference in the VAS, TUG, and CUS variables. Out of 30 participants, 26 participants completed the study protocol, 11 from the experimental and 15 from the control groups. Based on the repeated measure ANOVA and Banforone comparison analysis, the experimental group demonstrated significant improvements in the pain VAS, TUG, and CUS scores compared to baseline. Meanwhile, no significant changes were observed in the control. Relative to the control group, the experimental group presented higher improvement by 43% for pain VAS, 16% for time up and go test, and 41% for CUS assessment. As for the conclusion, integrating the home-based exercise and patient education program into usual NEOA rehabilitation showed to reduce pain and disability and improve functional mobility. It is believed that the home-based exercise and patient education program improve participants' self-management skill and boost the dosage of exercise therapy for optimal clinical outcomes. Therefore, this study suggests that a combination of structured home-based exercise and patient education program to be considered as part of mainstream management for NEOA. With that, I thank you.
Thank you, Dr. Muhammad Azwan. So I think we can start the question and answer session. Maybe I invite Prof. Sabarul. Do you want to ask any questions to Dr. Muhammad Azwan?
Okay. Assalamualaikum.
Assalamualaikum, Prof.
Yeah, can you hear me? Dengar?
Boleh, Prof.
Okay. So, few questions I want to clarify. You have two wings kan? One is the... Azwan tak nampak muka. Okay. So you have two wings. One is the experimental group.
Ya, Prof.
Follows this booklet ni lah.
Ya.
Exercise regime, all those things. Okay, you have a control group, home stretching exercise to equate the booklet ni.
Actually, that one is to equate the treatment time between the two groups.
Okay, treatment time will be the same.
Yeah.
So this home stretching exercise in the control group, is it the current exercise regime that you give to your patient at the moment, or is it a standard MOH punya treatment regime?
Actually, that one is we adapting the contents from different sources and also from the NEOA related studies. And then we try to simplify the content so that patient can perform the exercise easily at home.
No, I mean the control group.
Actually, for the control group, different kind of exercise, but just simple home stretching exercise for lower limb, especially for
simple stretching exercise. So is it the current exercise given by most of the physiotherapy centers ke whatever?
Yeah, that one is based on Prof. That one is based on the recommended guideline for the simple stretching exercise.
Simple stretching exercise recommended by Ministry of Health dan sebagainya kan?
Yeah.
Okay. Okay. So that's clear. You have this booklet which you are introducing and you're doing a study. And the control group is the normal one lah, yang the standard procedure that we do now.
Yeah.
Okay. So my question is, how come there are so much difference in terms of improvement as compared to the control? The improvement is so bad. Imagine in terms of the KOOS, control group improvement is only 1%. And the pain management control is only 2%. And the TUG also for control is 1%. So what you telling me, the current therapy given to all our patients are very ineffective. How do you explain that result?
Actually, we think that 8 weeks of intervention may be not adequate to see for the proper changes, especially for the control group. And then for the experimental, because we provide with the booklet and we did the home exercise diary, maybe their self-management skill and also their adherence with the exercise is much better. And that the dosage is better in some way.
So because in the control group, dia tak ada pamphlet ke apa ke dan sebagainya, is it?
Actually, we just, during the physiotherapy session, we just teach them the exercise and ask them to continue at home. Yes.
Okay, so it's only one session, then continue at home for 8 weeks, then you evaluate.
Yeah, and then after for the all participants, they just come for the regular physiotherapy intervention once a week for 8 weeks. As usual.
Once a week, or?
Once a week for 8 weeks.
For 8 weeks. Oh, so they still come now.
Yeah.
Okay. So you think in terms of adherence dengan ni is not as good as compared to your booklet?
Yeah.
So you're trying to say that you need a booklet like this to improve significantly.
Yeah, that's right.
And the current therapy yang kita bagi is not effective.
Maybe for the current therapy, some of them for the exercise is mainly, I'm not saying that not effective, but sometimes they not properly follow the.
Yeah, because only 1%, 2%, 1%, no.
Yeah, that's true.
It's like
quite
nothing.
Surprised.
Nearly zero. Is it? Because if you look at other studies, they show that there is improvement. And if you look at clinical setting, there is improvement. It's not like 1%. Yeah?
That's true.
Okay. Aniza.
Aniza, any questions?
Okay, Assalamualaikum. Hi Azwan. Congratulations. I know RCTs are not very easy studies. I was about to ask the same thing as Prof. Sabarul, because I noticed that you calculate your sample size based on a very large effect size. May I ask, where did you get that effect size? Which study did you calculate the effect size from in order to get your sample size?
Actually, for the sample size calculation, the parameters I refer to previous study which they investigated 2 groups and they able to with using almost similar outcome, and they able to detect the significant changes different between the 2 groups. So I referring to a previous study.
Okay, so do you think that your current findings match previous literature in which they also had the same result? The current therapy is really not effective. That's the thing. It is not effective compared to this home-based stretching. Or were there any differences compared to other literatures? What do you think is different in your study?
I think for the finding, there's some difference, and maybe because of the sample size, because I think the sample size is considered as quite small.
But you got a significant difference, so there is no type 2 error here. Maybe there is some problems with your methodology. Did you also get patients in the control group to be compliant to their standard of care?
And for this study, in both group, for control and also for the experimental, we call once for every 2 weeks, just to remind them, we test some to remind them to continue with the exercise at home.
Okay, tak apalah. So I will ask the soalan cepu mas. So
Anissa, sorry. That's the time that we have for
Thank you.
Okay, thank you, Prof.
Thank you, Prof. Aniza. Thank you, Dr. Azwan, because we have 10 presenters lined up, so we really have to be strict with our timing. Okay, thank you, Dr. Azwan. So can we have the video of the next presentation? The next presentation will be by Dr. S2 Miliani. Her paper is on validity and reliability of the Malay version of the lymphedema functioning, disability and health questionnaire for upper limb lymphedema in patients with breast cancer related lymphoma. So they submitted this as abstract C7. Can you please play the video?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. My name is Estu Melani, a postgraduate student from Physiotherapy Program, Center for Rehabilitation and Special Needs Studies, Faculty of Health Sciences, University Kebangsaan Malaysia. First of all, I would like to thank the 24th Medical and Health Research Week Committee for giving me the opportunity to present the results of my current study entitled Validity and Reliability of the Bahasa Malaysia version of the Lymphedema Functioning Disability and Health Questionnaire for Upper Limb Lymphedema or LIM ICF-ULBM in patients with breast cancer-related lymphedema. According to WHO, breast cancer is the most common cancer diagnosis among women around the world, with more than 2 million cases in the year of 2018, with 670,000 deaths in the same year. And Malaysia itself, as reported by Malaysia National Cancer Registry, breast cancer had infected more than 20,000 women in the period of 2012 until 2016. Furthermore, breast cancer had caused the disability such as arm stiffness, daily activity restriction, and stress in approximately 25% of all cancer patients in Malaysia. And despite improvements in many treatment options for breast cancer, lymphedema remains the most prevalent morbidity of post-breast cancer treatments. Patients with breast cancer-related lymphedema or BCRL can suffer from various problems in physical, social, and mental functionings, which subsequently will mitigate their quality of life. Hence, according to a few studies, it is important to include a comprehensive quality of life assessment into the series of BCRL management in order to address the BCRL symptoms more properly and improve the patient's quality of life. Meanwhile, the LIM ICF-UL is one of the lymphedema-specific questionnaire that has proven to be a valid and reliable instrument for assessing quality of life in patients with BCRL. However, there is no one ever read the Bahasa Malaysia or BM version of the questionnaire yet. Therefore, the objective of this study were to produce and also to validate the BM version of the LIM ICF-UL. This study have been approved by the Ethical Committee of University Kebangsaan Malaysia or GEP-UKM on 16 December 2020 and also by Medical Research Ethical Committee of Ministry of Health Malaysia on 8 March 2021. And the population of the study was female patients aged 18 until 75 years old who were receiving or had received treatment in Hospital Kuala Lumpur, Hospital Kanselar Tuanku Muhriz, and also Institut Kanser Negara at any time from March 2021 to March 2022. The samples were chosen through a purposive sample method. The study also consists of the study method or procedure consists of forward and backward translation and also a series of psychometric properties assessments which include phase and content validity assessment in 6 expert and also 5 patient and also construct validity and internal consistency analysis in 109 patients respondent. And lastly, the test-retest reliability analysis in the 21 respondents. The study started with the forward and backward translation process of the LIM ICF-UL from the original language, which is English, into the target language, Bahasa Malaysia. The permission to translate have been obtained from the original developer, which is Professor Nele Devout. The translation process saw no major loss in the general meaning of the sentence. And also, all 5 patients found the scoring system and also the items, 27 of the total 29 items, clear and relevant, which indicated a good face validity. And also the result for content validity assessment by 6 experts, which evidenced by content validity index or CVI, and also modified kappa statistic, had demonstrated a good content validity. In addition, majority of patients and experts had suggested us to remove 2 items, which is item number 20, berjemur, and also item number 23, which is menunggang basikal, because these items are not relevant for patients who is living in Malaysia. And therefore, the final limb ICFU LBM consists of 27 items. Moving on, the construct validity analysis in the 109 patients had detected acceptable fit indices, indicating a good construct validity. Moreover, the Cronbach alpha value for all domains and the total scores of the limb ICFU LBM were higher than 0.60, which indicated an acceptable internal consistency. Next, the retest or the reassessment was conducted in 21 patients 2 weeks after the first assessment. The test-retest reliability estimate, which consists of interclass correlation coefficient for relative agreement, SEM or standard error measurement for absolute agreement, and also Brand-Altman plot for limit of agreement, had demonstrated a good test-retest reliability. These results were in accordance or agreed with the validity and reliability of the original version as well as Danish, French, and also Chinese versions of the LIM ICFUL. And finally, to conclude, the LIM ICFU LBM has a good validity and reliability in evaluating quality of life of patients with breast cancer-related lymphedema in Malaysia. That is all my presentation of my result, the presentation of my result. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. So I would like to invite Prof. Anissa first, perhaps to give a question to Dr. Estu.
Thank you. Assalamualaikum. Hello, Estu.
Hello.
Okay, thank you for the presentation. So I just want to clarify a number of things. I think you did not go into very detail on the inclusion and exclusion criteria for the patients to do your construct validity. Can you tell me what were the inclusion and exclusion criteria for the patients?
Yeah, sure, Prof. Wait. Okay, so for the inclusion criteria for the patients, one had been diagnosed with unilateral or bilateral BCRL or breast cancer-related lymphedema, and female aged 18 until 75 years old, and currently undergoing or had undergone treatments for their BCRL in HKL, HGTM, or IKN, had been treated with surgery for breast cancer, which are mastectomy, lumpectomy, LND, SLND, etc., had completed radiotherapy and or chemotherapy, are mentally capable to read, speak, and comprehend in Bahasa Malaysia, and are willing to participate in the study by signing an informed consent. Meanwhile, for the exclusion criteria, do you want me to read the...
It's okay. I actually wanted to know because it was not clear that you were recruiting a breast cancer patient who already had lymphedema. Since you are measuring that quality of life, it's very important that you only recruited patients who had the lymphedema.
Yes.
My second question is that you have proven that it has good reliability, internal consistency, and construct validity. How will you use this questionnaire in your clinical practice?
Okay, so for the LIM ICFUL is the one of lymphedema specific self-reported questionnaire. So it is the patient who fill out the questionnaire. So it's important to use in the to see the effectiveness of the treatment for the breast cancer lymphedema patients. And because given the fact that BCRL affect the way patient feel and function, so it's patient reported outcome measure is suitable for the clinical use.
Okay, thank you very much.
Okay.
Over to Prof. Sabarul.
Assalamualaikum, Estu.
Yeah, Waalaikumsalam.
Okay, yeah, I think very important effort to validate Bahasa Malaysia version of the questionnaire. So first thing I would like to ask you, can you briefly tell me what is what are the domains do you look into in this questionnaire?
Oh, so what is the domains in the questionnaire?
Yes.
Okay. So this questionnaire consists of 5 domains, which are physical function, mental functions, and then household activity, mobility activity, and social activity.
Okay, so those are the domain. Based on your study, you have omitted 2 questions.
Yes, I omitted 2 questions.
And from which domain is that question and why?
The domain
Why
is
relevant in Malaysian context?
okay. So the domains is from the mobility activity, which are item number 20 is berjemur or sunbathing, berjemur or sunbathing, and then the
Sunbathing. Okay.
sunbathing, and then
number
item 23 is menunggang bicycle or ride bicycle. So
okay.
it's not according to our experts and also the patient in the pilot testing. It's not relevant for the Malaysian context.
Yeah, I
Malaysian
agree.
culture. Yes.
So go on vacation, everything is okay.
Yes, everything is okay because everyone is still going to vacation, even the visceral patients.
Okay.
According to
And my question is, when you do the study, in your study, do you evaluate the education level of your participants?
Oh yes, I also documented the education levels.
Okay, so majority are
high school, from high school, majority of the patients.
high school above.
Yes, high school level.
Because this is a self questionnaire, so all your participants can actually read your questionnaire, is it?
Yes, they can read the questionnaire.
So it's own self-reading. You do not have to interpret when you do the study.
I have to explain for the Chinese patients and then the Indian patients.
So you also have Chinese Malaysian inside your study.
Yes, all
which are not so fluent in Bahasa Malaysia.
They can comprehend in Bahasa Malaysia, but not that.
But you have to translate. So
yeah, they still need a few explanation.
Yeah. So that defeats the purpose of your sampling. It should be people who are versed in Bahasa Malaysia. That's the reason when we want to validate, you should not intervene the process of the questionnaire. It's a self-explanatory questionnaire. You understand or not?
Yes.
So that's my comment on your methodology. Okay, thank you.
Thank you, Prof. Barun, Prof. Aniza, for the comments as well as the questions. Thank you, S2, for presenting. So we'll continue by inviting the next speaker. The next speaker is Dr. Nur Adila Abdul Hamid. She'll be presenting abstract C12 and her topic will be maternal serum ferritin levels and association with preterm birth. Can we have a video?
Assalamualaikum warahmatullahi wabarakatuh and very good morning. I am Nur Adil Abdul Hamid from Department of Pathology, Faculty of Medicine, University Kebangsaan Malaysia. Today, I'm going to present my poster entitled Maternal Serum Ferritin Levels and Association with Preterm Birth. My main supervisor is Cik Khalida Mazlan Bador from Department of Pathology, Faculty of Medicine, University Kebangsaan Malaysia. My co-supervisors are Dr. Nur Maizwana Muhammad Mukhtar from Department of Pathology, Hospital Kuala Lumpur, and Professor Dr. Nur Azlin Muhammad Ismail from Department of Obstetric and Gynecology, Faculty of Medicine, University Kebangsaan Malaysia. Let's have a look. Preterm birth is a major cause of perinatal mortality and long-term morbidity. Higher serum ferritin level was reported in pregnant women with preterm delivery. However, most studies involve peripartum ferritin. The objective of our study is to determine the relationship between antenatal serum ferritin level and preterm birth. This was a retrospective study of pregnant women who delivered at Hospital Chancellor Tuanku Mukhris between January 2013 and December 2020. We included cases with serum ferritin measured antenatally and excluded cases with chronic diseases, iron disorders, uterine or cervical anomalies. Demographic data, pregnancy characteristics, and medical data were retrieved from the hospital's patient information systems. Then, data on the serum ferritin levels were analyzed in preterm and term groups. As the results, a total of 202 women were studied, of which 27 or 14.4% had preterm delivery. Most of the ferritin measurements, around 80% in the term and preterm groups, were taken during the third trimester. We found there was no significant difference in the median and range of antenatal ferritin level between the preterm group and term group. The level was 15.81 microgram per liter with a range of 10.09 to 32.41 microgram per liter in the preterm group and 16.11 microgram per liter with a range of 9.09 to 34.38 microgram per liter for the term group. The p-value was 0.801. Although not significant, there was a doubling of ferritin level in the second trimester among preterm cases, which did not occur in the term group. As illustrated in Figure 1 that shows the serum ferritin trends in the term and preterm groups, in which the blue line represents the term group and green line represents preterm group. In the term group, the serum ferritin level in the first trimester was 20.48 microgram per liter. This level was reduced to 16.67 in the second trimester before it further declined to 15.35 microgram per liter in the third trimester. The trend of serum ferritin level in the term group is following the normal physiological changes of ferritin level in the normal pregnant women population. However, this trend was violated in the preterm group. The level was 16.60 microgram per liter in the first trimester, then it shot to 30.13 in the second trimester before it reduced to 15.16 microgram per liter to the level that almost the same as the term group. Nevertheless, we did not find any significant difference between both groups regarding the serum ferritin trend. The increment of serum ferritin levels during the second trimester may be part of the acute phase response involved in the inflammatory process associated with preterm birth, which is evident from the early trimester of pregnancy. We did not find any significant association between maternal serum ferritin level and preterm birth, maybe due to the relatively small study population and day-to-day variability of serum iron. As for conclusion, further studies involving serial measurements of ferritin may provide better predictive utility of this biomarker in the early detection of preterm birth. Last but not least, listed here are my references.
Yes, I think we can invite questions. So maybe Prof. Sabaru would like to start.
Okay, yeah. Assalamualaikum, Dr. Nur Adi.
Waalaikumsalam, Prof.
Okay, so it's a very interesting finding, and I think it's a very important in terms of clinical to detect factors of preterm labor. And okay, so when you see there's the doubling of the ferrum at the second trimester, is there anything in terms of clinical aspect that it can do in terms of preventing from a preterm labor? How significant is the increase in the ferrum level in terms of your clinical management?
Well, actually, from my analysis, the difference was not significant. Actually, other than this, I did try to correlate other clinical parameters, but none of them was significant. So for the time being, there's no recommendation that I can say for now, but perhaps a further study is needed to confirm this.
Another one, serum level is not a routine check-up ni kan, routine
Yes.
test do during antenatal punya check-up kan?
Yes. It's not a routine, but considering iron deficiency anemia in pregnant population is quite relatively common, so that's why ferritin comes in hand. So ferritin, although it's not a routine, but because of this iron deficiency anemia, ferritin was sent for analysis. That's why can be said more than 50% of the pregnant women have ferritin level.
Okay, so let's say in clinical setting, if you have someone who has high risk of preterm labor, meaning from previous pregnancy, and anemia, there's evidence of progressive anemia, would you do ferritin level for this patient to see whether it will progress into a preterm or not? Or
yes, because other than representing iron storage in the body, anemia, ferritin also represent the acute phase reactants, where it presents any infection or inflammations in the body, and this level somehow could help us in predicting the occurrence of preterm birth in the later on.
so if you say inflammation is not preterm, what are the precautions that you can do in terms of preventing a preterm due to inflammatory process?
We can start the treatment earlier if we manage to catch this. So
okay,
perhaps with earlier interventions, the preterm can be reduced.
So what type of treatment in terms of preterm, in terms of inflammation?
In case of infections, probably we can start antibiotics.
Okay. Thanks.
Saya ada masa sikit ke? Boleh?
Ada.
Okay, hi Adila. Okay, after listening to your presentation, I mean that in the second trimester, you use median values and you did not show us the distribution, which is the interquartile range between your groups. Hence, I suspect it's probably large and overlapping, hence why there is no significant difference. So I would caution you in making that statement that there is a surge in the second trimester, because in reality, when there is no difference, there is no surge, and this is misleading. This is misleading. Your discussion is not supported by your data. So that's just one thing I want to just clarify with you. Another thing is being retrospective. I suspect, and it's not routine, I suspect there's a lot of missing data in your population. How was that dealt with?
Yes, exactly. Agree with you, Prof. Actually, out of 1,620 patients, I only managed to include 202, which means I exclude more than 1,000 patients because of the incomplete data.
And did the included data had serum ferritin in all trimesters, ataupun as long as they have in one of the trimester, you take it?
Yes, as long as they have.
Okay. So it's very hard to draw a conclusion based on that data. So moving forward, how would you improve your study or to do this again?
I would like to suggest prospective studies which do serial collection of serum ferritin starting from first trimester, second and third. So we can conclude based on this because it's more robust compared to retrospective.
I would recommend a case control design type of study. Thank you. Just in time.
Thank you. So thank you, Dr. Adila. So we'd like to invite the fourth presenter for today. So the fourth presenter from abstract C16, Dr. Arina and Dr. Nur Afifah will present on their topic, which is evaluation of sensibility on tooth previously involved in cystic jaw lesions. So I would like to invite Dr. Arina or Dr. Nur Afifah to present their thesis. We have the video.
Assalamualaikum and good morning. I bid to the chairperson, to our esteemed judges, Professor Datuk Dr. Sabarul Afian Mukhtar, Professor Madya Dr. Anisa Khairiyah, lecturers, doctors, and everyone that is present here today. We were given the research code C16, and I am Arina binti Muhammad Asri.
I'm Siti Afifah binti Ramli, and today we would like to present our research entitled
evaluation of sensibility on tools previously involved in jaw cystic lesions. So now, let's start with the top left part of the poster. First, what are odontogenic cysts? Odontogenic cysts are jaw pathological cavities that are lined by cells arising from odontogenic epithelial origins, and they are encapsulated by a fibrous connective tissue. Cells arising from odontogenic epithelial origins give rise to odontogenic structures, such as the enamel and also the periodontal ligament. As such, odontogenic cysts generally are related to the tooth. The roots or apices of teeth adjacent to a pathogenic tooth, which are the tooth in which the cyst originates, are often radiographically found in cystic cavities measuring more than 5 cm due to their expansion. As such, the sensibility of these adjacent teeth may be affected by the cyst. Treatments for these odontogenic cysts include, but are not limited to, enucleation with or without marsupialization and jaw resection. Total enucleation of the cyst along with the extraction of the pathogenic tooth is among the most conservative treatment modality. There is still a dilemma whether prophylactic root canal treatment should be carried out on the adjacent affected tooth or a more conservative approach utilized, as during enucleation, the adjacent teeth are often affected by the surgical procedure. So now we move on to the next question. What is tooth sensibility? Tooth sensibility is defined as the pulp's ability to produce a response upon a stimulus. Meanwhile, tooth vitality is the presence of blood flow in the pulp. However, it is important to note that even in the absence of innervation, a pulp can still have blood flow. As such, tooth sensibility is not regarded as a true measure of health. However, in this study, we use tooth sensibility because it is the most common readily available instrument in a clinical setting. For example, we use the electrical pulp testing and also the cold test to test the sensibility of the tooth. Meanwhile, a true tooth vitality test needs a laser Doppler flowmetry instrument, which requires a higher technique in handling it, and it is also a highly expensive instrument.
Our aim of this research is to assess the impact of cyst enucleation to the teeth associated with cysts, specifically their sensibility post-cyst enucleation. Next, if you move down to the middle of our poster, there will be the methodology. This research is a retrospective study examining patients previously treated for odontogenic cysts at the Oral and Maxillofacial Surgery Department of Hospital Chancellor Tunku Mukhris, or HCTM, from the 1st January of 2000 until 31st December 2021. We started off screening a total of more than 700 patients from surgery records in UKMMC from the year 2000 until 2022. From that, we obtained 88 patients that had undergone enucleation surgery. Only 63 patients had folders available, while 25 didn't. To further go down the line, we had to screen them using our inclusion criteria, which are patients who had undergone cyst enucleation procedure in HCTM UKM. Lesion must be histopathologically proven to be radicular and or dentigerous cyst only. Affected tooth must have had sensibility testing done pre-operatively and post-operatively. Associated tooth must be sensible pre-operatively, and lastly, pre-operative radiograph of the cyst must be available. This led to only 19 patients who had met our inclusion criteria and 44 patients that didn't. From those 19 patients, we acquired 85 individual teeth and 115 readings. The 115 readings are cumulative post-operative readings. Thus, the total number of samples that we will be analyzing comes from the 115 readings, meaning mean reading intervals between the pre-operative and the post-operative EPT readings were calculated and classified respectively. The analysis for this research was done using Statistical Package for the Social Sciences, or SPSS version 26.
Next, the results can be seen at the lower portion of the poster. There is the results for the gender and age demographics data. Here we can see for the mean age for the dentigerous cyst, the mean age is 42 years old, while for radicular cyst, it is 35 years old. Moving on to the gender prevalence for dentigerous cyst, females have a higher prevalence of 81.20%, while male patients is at 18.80%. For radicular cyst, in converse, male has a higher prevalence with 60%, while female has 14%. Adjacent to this would be the race distribution. For the integer cyst, Malays reported the highest percentage with 37.5%, followed by Chinese at 31.3%, other Malaysian with 88.8%, and Indian at 12.5%. But among radiculocyst patients, it is widely dominated by the Malay population with 65.7%, followed by Chinese 25.7%, and other non-Malaysian at 8.6%. Now, let's move on to the changes in EPT readings of affected teeth after surgery at the lower portion of the poster.
Now, let's take a look at the graph showing the changes in EPT readings of affected teeth after surgery. The intervals times after the date of surgery were obtained by finding the difference in days from the post-operative reading and pre-operative reading. Then, EPT readings were categorized accordingly. The categories are less than 1 month, there's 14 readings, 1 month to 3 months, there's 32 readings, 3 months to 6 months, there's 32 readings, 6 months to 9 months, there's 15 readings, and more than 9 months, which has 22 readings. Changes of tooth sensibility was measured by the difference of EPT reading, starting from the pre-operative reading and the post-operative reading. If there was a decrease in sensibility, the changes would have a positive integer and vice versa. Due to the SQ results, median will be used instead of mean to explain the distribution. From this graph, a pattern can be seen when there is an increase in changes of EPT reading under 1 month post-surgery, meaning there's a decrease in the sensibility of the tooth. The changes decreases from 1 month up to 9 months after surgery. This brings forward that the sensibility of the tooth has been increased. Lastly, there is a decrease in sensibility after 9 months post-surgery as the changes increase in value. The conclusion is, it is not absolute that the teeth with episodes involved within a cyst cavity will be non-vital following enucleation. It is recommended that these teeth should be reassessed for a minimum of 3 months post-operatively before proceeding with root canal treatment. With that comes the ending of this presentation. Thank you for joining us. We would like to express our gratitude to our supervisors, Professor Syed Nabil Syed Omar, Professor Nazimi Jafar, and Encik Fazli for the statistical analysis. Thank you.
Thank you, Afifa, for the presentation. Now I would like to invite perhaps Prof. Aniza. Do you want to start with the questions?
Hi, Assalamualaikum, Afifa and Arina. I really enjoyed listening to your presentation. I thought it was very creative, very clear. Congratulations. Okay, so my first question is just to clarify a few things. Number one is, your inclusion criteria is that the tooth must have intact sensation prior to the enucleation. How was that determined? As I see that there is no pre-op EPT result. Tiba-tiba tak boleh unmute.
Just click unmute button.
Yeah. Okay. Actually, in our inclusion criteria, we have already stated that the tooth must be sensible pre-operatively in such a way that it actually has a pre-operative EPT reading.
So one of the inclusion criteria is that they must have EPT reading that showed it was viable. It was viable, correct?
Yes.
Okay. Okay, then you should make that clear in the inclusion criteria as well. My other question is that when I saw your graph, you show that at post-op, the affected teeth, it will be quite intact, and then it drops at 3 months. Then after 9 months, I noticed that there is some improvement. So my question is, why do you then recommend that you only do the EPT reading at 3 months before deciding to extract the tooth? If I understand correctly, shouldn't it be more than 9 months? I mean, give it a chance to recover based on your data.
Sorry, so actually, in our conclusion, after the 3 months, it shows an increase in sensibility. Sorry. After 3 months, it already shows an increase in sensibility. However, after the 9 months, then it might show a decrease or an increase in the sensibility as the changes is not that significant. So what we are hoping from this research is that the tooth should be assessed at least 3 months in minimum, because among the patients record that we found in the HUKM is that some of them are not even reassessed after the enucleation procedure. So yeah, we are recommending that at least a 3 months follow-up should be done towards this tooth.
I see. Okay, thank you very much. Okay, over to Prof. Sabarul.
Ya, Assalamualaikum. Afifah dengan Narina. Ya, I echo Prof. Aniza punya komen. Very innovative way of presenting. So anyway, in terms of clarification, when you have a cyst inside your tooth, once you inoculate, how many percentage usually need to go for extraction eventually? Besides the sensitivity of the teeth, what are other criteria where you extract the teeth? Is sensitivity important? Because as far as I know, sometimes the sensitivity of the teeth is not important. That's why you do root canal. So it becomes asensate, but it is still functional. Yeah, so that part I wasn't clear in terms of your the purpose of your study. Kan when you do root canal is asensate kan, dia tak ada sensitivity langsung kan. So that part I wasn't clear. What are you trying to tell us?
Okay, so depending on doctors, they might just go for prophylactic root canal treatment, which is before they do the enucleation of the cyst, they will proceed to non-vitalize the adjacent tooth, so that after the enucleation process, this adjacent tooth won't have any complications, such as inflammatory residual cyst after that. However, as we have been taught in dentistry, we practice conservative dentistry. If the tooth can be maintained the vitality after that, then we elect not to do anything to it. So throughout this research, we are finding out whether a tooth needs to be prophylactically root treated before, or maybe immediately after the enucleation treatment, or not, or we just monitor the tooth and let it be, vital after the enucleation. Yeah.
Okay, so let me clarify again. So the study is not looking at hypersensitivity of the tooth after inoculation, is it?
Yeah.
It's not hypersensitivity.
Yeah, we are looking if the tooth would gradually be non-vital after the inoculation procedure.
Okay, thank you.
Thank you so much,
Prof. Sabarul and Prof. Aniza, and also Afifah and Arina for the presentation. So we'll move on to the fifth speaker. So the fifth speaker is Dr. Nur Ayub Muhammad Ali and Dr. Khatijah B. So they'll be presenting their paper on efficacy of early incremental supervised resistance training following cardiac surgery via median sternotomy, a pilot safety and feasibility randomized control trial. So can we have the video for C17?
Assalamualaikum and good morning. Thank you to panel judges, Professor Datuk Sabarul and Professor Madia Aniza and Chairperson. I am presenting on behalf of our research team, Dr. Nur Ayub and team. The landmark study collaborating with International University and local hospital with a title Pilot Feasibility and Safety or Early Incremental Supervised Resistance Training following median sternotomy randomized control trial with abbreviation SPRITS. Disclaimer, I have nothing to disclose. Median sternotomy is a common incision with 2 million procedures worldwide. To promote normal healing and prevent sternal complication, patients typically receive a list of upper limb activities to avoid. This set of activity restriction is known as sternal precaution. These precautions are prescribed routinely after median sternotomy with variable periods of time from 4 weeks to 3 months post-op. Study has shown that this restriction delay recovery and increase length of stay. In a recent survey conducted on Malaysian Cardiac Center, reported 80.5% placing restriction on upper limb and resistance training exercises from 6 to 8 weeks after median sternotomy, which is also a current standard in Malaysia. The rationale for this conventional sternal precaution is that they are thought to minimize forces on the sternum. However, the evidence of conventional sternal precaution efficacy is low and were based on anecdotal evidence from limited numbers of cadaver studies, expert opinion, and hospital protocol. In particular, the duration set for sternal precaution of 6 to 8 weeks appear to be based on the principle of fracture of the healing of the long bone. A recent study using ultrasound on the sternal edges, measure upper limb and trunk task, result in minimal sternal micromotion, less than 2 millimeters between the sternal edges. This is within acceptable guidelines for healing. There is insufficient evidence to support the current guideline of 6 to 8 week wait post-surgery on upper limb activity. Early and supervised incremental resistance training within first week post-operative period following median sternotomy may be an important component of effective cardiac rehab phase 1 continue to phase 2. Study has reported movement in the tube and early upper limb activity to be safe, feasible with no increase in sternal complication rate. Worldwide guidelines, CTS and ERAS cardiac surgery guideline recommended movement in the tube and early upper limb activity that the current 6-week wait following median sternotomy, but how early can we start and how much load can be used without compromising healing of the sternum? Therefore, we embark on a pilot study with primary objective to evaluate the feasibility and safety of early incremental supervised resistance training following median sternotomy. The secondary objective were to assess the effectiveness of incremental upper limb resistance exercises in improvement upper limb function and sternal pain at 4 weeks and 3 months post-operative. The inclusion was adult elective cardiac surgery and the exclusion were emergency operation and resident outside Colombo. Ethical approval were attained from University Bangsaan Malaysia. The pilot study was conducted in Hospital Chancellor Tuanku Mukris. The protocol was registered with ICTRN. This is a phase 2 prospective randomized control trial, double-blind patient and outcome assessor. We use block randomization 1 to 20 per group. The intervention was delivered via face-to-face individual treatment, 1 to 3 sessions supervised in a week. Participants in the standard care group received pre-operative sternal precaution in the form of keep your move in the tube and post-operative progressive mobilization program and participate in active upper limb foot and ankle exercises. The intervention group received similar intervention with the addition of early incremental supervised resistance training. This is our early incremental supervised resistance training protocol. In our study, we developed a new weighted PVC exercise bar known as Impact Bar, TM registered as UKM intellectual property. This is innovative bar developed based on biomechanical principle to prevent distraction forces on the sternum while keeping both arms by the side during resistance exercise training. The total sample size was calculated on the primary outcome using unsupported upper limb test, 120 per group for the definitive study. For the pilot study, 10% of participants from each group were reported at HTCM. The primary outcome were feasibility defined as recruitment adherence in the intervention group and safety is determined by sternal wound complication. The secondary outcome were upper limb function using unsupported upper limb exercise test and numerical rating pain scale for pain. Secondary outcome were measured assessed at pre-operatively prior to discharge, 4 to 6 weeks and 3 months post-op. Because data is not numerically distributed, all parameters were analyzed with non-parametric tests. The changes between group different analyzed using Mann-Whitney U test and Freeman test for within group different. P-value of less than 0.05 is considered significant. This is participant flow chart. 67 were screened with 40 participants recruited, 27 were excluded as highlighted in the slide. 2 participants lost to follow-up at 4 to 6 weeks post-operative due to logistic and financial issues. I'm now going to present the result. There were no significant difference between group at baseline. The sample size was typical of cardiac surgery population with the mean age being 58 years old and the gender distributing biasing male reflecting cardiac surgery population. The intervention was given treatment earlier compared to the control group within inpatient setting. With respect to adherence to the precaution, 70% of participants within both groups believe they have been following the movement in the tube instruction. There is no adverse event, as you can see, and no sternal complication developed in both groups consistent with the current evidence. From the primary outcome measures, as you can see, during hospitalization, post-operatively, both groups have upper limb impairment in the upper limb score, indicating effect of the cardiac surgery. Patient improved this measure and upper limb function and pain over time after surgery, which is consistent with the improvement as a result of cardiac surgery. The table demonstrates that significant difference in upper limb function for intervention at early post-op period, but there was no significant difference between groups measured at 4 weeks or 3 months post-op. This is a first pilot studies randomized control style on use of movement and tube sternal precaution and early resistance training exercises with robust methodology. The protocol can be delivered safely and successfully to patients in the first week medium sternotomy using our innovation in bar to facilitate upper limb tests and assist in early recovery. Early resistance training exercises did not cause any harm and adverse event, which is often a concern practitioner managing this population. The protocol shows acceptability of patient recruitment, early commencement of phase 2 cardiac rehab in our cohort. The strength of the study, it is a first randomized control trial pilot conducted in accordance to consult guidelines to address evidence gaps. The attrition bias is low, where only 2 participants were lost to follow up. There is no adverse event. In conclusion, a program of less restrictive sternal precaution, in addition to early resistance training, can be delivered safely and successfully to patients in the first week median sternotomy. Future, it was therefore recommended to progress into multi-center phase to definitely test the effect of early resistance training. We are now at phase 3 to study multi-center randomized control trial, working with our collaborative partners from Ministry of Health and Institute Jantung Negara, assessing the efficacy and cost-effectiveness study. With that, I concluded my talk. Thank you.
Thank you, Dr. Khatijah B. Very interesting topic, and they use the Interact bar, very nice too, like and it looks very stylish too, multiple colors. So I would like to invite Prof. Sabarul perhaps to start with the question and answer.
Assalamualaikum, Dr. Khatijah.
Waalaikumsalam, Prof.
Yeah, very excellent. Yeah, it's a very interesting study, especially when you include your innovation of the bar.
Yes.
Kan?
Yeah.
So yeah, I'm surprised that actually you do not start immediate upper limb exercise patient post cardiac. I thought it should be safe enough. So
this is what we thought. That was 20 years ago because of the study. Because of one study on cardiovascular study, and there's the upper limb exercises and put sternal.
So they delay until 6 weeks, eh?
Yeah, even now in Malaysia is still a standard guideline all over Malaysia. And
so
worldwide too.
That okay, your study, do you think it will change in terms of management?
Yes,
especially the first 1 week, you have shown that it is effective and it doesn't cause any complication.
That's why we think that it's a landmark study. We actually break the breaking wall. I mean, we actually breaking wall all this as a perspective. We want to change it. We want to change the guideline in terms of upper limb exercise activity.
And one of the complication that is a major complication is the wound breakdown.
Wound complication, yeah.
Okay.
But we don't have it in our study, yeah.
Yeah, but the thing is, I've noticed that among your control dengan standard group, your experimental group dengan standard group, your standard group is slightly more obese as compared to your 28 kan?
Yeah, but then it is a randomized control. We did not stratify it. We think that it's robust enough. We just let it be. We asked the statistician and said it's robust enough, and then because it's a but this is a pilot study. We hope that it's going to change a little bit more when we have the full definitive studies.
Okay, so 1 week significant, but others is the same. So basically, you start early je lah. That's the conclusion kan?
We start earlier, meaning we start early than any other. What is the guideline recommended?
Okay, yeah, excellent. Thank you.
Prof. Aniza, any questions from you?
Yeah, I mean, I thought it's very interesting, but maybe because I'm not really don't really understand cardiothoracic surgery, so I'm a bit, actually I was a little bit lost. Maybe Khatijah can help me explain just a little bit. And what is the end outcome and the hopes of starting this physio, this exercise early compared to the standard of care now, which is you start a bit later because you're worried about wound breakdown?
Yeah, well, because sternal precaution has been delayed for 6 to 8 weeks, and then when you start cardiac rehab at 6 weeks, what happened is that patient return to work later, So and then even driving, we start at 3 months after post-op. But then in our patient, what we did, but we actually collect the data, return to work, as well as early driving, meaning based on the guidelines that we don't have, Malaysia doesn't have guidelines how early that the after cardiac surgery patient was able to actually drive. But in our case, at 4 weeks to 6 weeks, patient was able to drive early return of work and early driving. So this is a very significant in terms of clinically. I mean, it's cost effective. We think that it's cost effective, but we will be tested it in our multi-center clinical trial because early return of work implication, early return of work, early return is translated into cost effectiveness. Definitely people wants to come, because another thing is that cardiac rehabs, the uptake and adherence is very low, 40 to 60%, even in IJN. But with earlier rehabs, we feel that it's going to be more adherence, more uptake, because of the evidence surrounding around it is actually a level 1 evidence.
Okay, thank you very much. Okay, it's clear now.
Okay. Any other questions, Anissa?
Tak ada.
Okay, thank you Dr. Katijabi and Dr. Ayub for their presentation, and all the best for the subsequent phase of the study. Hopefully you get more participants and be able to change some guidelines in Malaysia. All right, so I would like to invite the next speaker. The next speaker is Dr. Chin Lee. Dr. Chin Lee will be presenting abstract C19 titled Otitis Media Effusion and its Association with Early Childhood Caries. So can you have the video for C19?
Very good morning, everyone. I'm Dr. Chin Lee. Today, I'm very honored to be here to present my e-poster with the title of Otitis Media Effusion and its Association with Early Childhood Caries. Otitis media effusion, OME, is a middle ear disease affected 50% of the children in the first year of life and increasing to more than 60% by age of 2, and the screening surveys of healthy children ranging from infants to 5 years of age show a 15 to 40% prevalence of OME. Early childhood caries, ECC, another common childhood medical problem with high prevalence among 6 years old in Malaysia, with only a small decline from 80.9% in 1997 to 74.5% in 2007, which is far from the WHO oral health goal of 50% caries-free. This study aims to determine the association between the otitis media effusion, OME, and early childhood caries, ECC, among the preschool children. The specific objectives include to determine the prevalence of OME and ECC in preschool children, to determine the risk and severity of ECC in OME patients, and to study the diagnosis of OME by clinical evidence of tympanometric leaf. This is a prospective cross-sectional study in a tertiary academic center between 2018 to 2020 involving children aged 1 to 6 years old with hearing impairment or speech delay, and they were grouped as with or without OME. Demographic and socioeconomic data were obtained, followed by otoscopy, anterior rhinoscopy examinations, and tympanometric assessment. Then, all subjects were assessed with caries risk assessment, CRA, to determine the risk of ECC. A dental examination was performed to assess the severity of ECC, mild, moderate, and severe, and documented in the dental charting. Tympanometric width, TW, was analyzed to measure its association with tympanic membrane appearance. Let's look at the results. A total of 206 children were recruited in this study. Out of 129 children were diagnosed with OME. 82.2% were found to have ECC, 17.8% without ECC. 23.4% children without OME had ECC. OME and ECC group showed male preponderance, with most of the patients are from the age group of 2 and below. CRA showed that 51% of the children with OME carry a moderate caries risk. However, analysis of the dental charting showed the majority of these children, 49.1%, were assessed to have a mild ECC, followed by 30.2% with moderate ECC and 20.8% with severe ECC. 52% of this population were found to be significantly associated with underlying medical problem, which comprises of allergic rhinitis and eczema. A significant association was demonstrated between ECC and the occurrence of the OME with the p-value less than 0.001 among these children. Tympanometric with more than 200 decapascal documented an association with abnormal tympanic membrane appearance in OME. The present study indicated that the risks of OME are found to be significantly higher in the children who have ECC at the age group of 2 and below. The higher prevalence of OME in this age group may be explained by the immature immune defense and the more horizontal and wider anatomy of the eustachian tube. Children with OME had a significant moderate caries risk to at least have a mild severity of ECC through the dental charting. The implementation of the caries risk assessment and dental charting may allow the clinicians to predict the severity of the disease and subsequently to plan the preventive measures. The advantage of this is the ability to identify those who are at risk even before the manifestation of the severe caries lesion. There is high prevalence rate of allergic rhinitis among children with OME, which suggested that the association between the underlying medical history and OME. This has shown that the underlying medical problems such as allergic rhinitis and OME may predispose the caries formation. A doubtful otoscopy findings of OME can be complemented by TW, the tympanometric width. As conclusion, early detection of OME with ECC is very important, and if left untreated, it will affect the speech and hearing development. Caries risk assessment, which focuses on the lifestyle risk factors, has shown to be useful in detecting ECC in OME children. Tympanometry width is a useful complementary measure to diagnose the OME accurately. Early detection of OME with ECC can accurately be done via routine screening in preschool children using caries risk assessment and a complementary tympanometric width measurement to improve their quality of life with prevention of complications. With that, I thank you for your attention. Thank you very much.
Thank you, Dr. Chin Lily. I would like to invite Prof. Aniza to start with the question and answer.
Hi, Lily.
Hi, Prof. Good morning.
Hi. Thank you for coming to Research Week and presenting your study. Was this your dissertation, Lily? Oi, hang.
Hello, yes, Prof.
I tengok your face is frozen.
Oh no, okay.
But I can hear you. It's okay. We'll see your frozen
Okay,
face
yeah.
then.
Sorry about that.
So was this your dissertation, Lily?
Yes, correct, Prof. This is my dissertation.
And have you published this yet?
Trying my very best.
I see.
I've been
Okay.
trying, yeah.
My feedback regarding the study is that I think I just have some clarifications regarding the methodology. Why is it you are looking at children within the association between caries and otitis media with effusion? So, and you state that caries is very common, about 80%. So I would infer from this that you probably have to look for OME among children with caries. Am I right?
Yes, basically there was a convenient sampling. So when patient presented to ENT clinics, those with a complaint of speech and hearing impairment, then we will recruit this patient. So while examining,
Yeah, so why is you didn't do it the other way around, which would make this, a much more robust methodology? Why do you select patients who already had hearing impairment, then look for OME, and then you divided OME without OME who have caries and no caries? It's sort of, and it's very hard to make inferment from that. How do you explain that? Why do you choose this? Why not the other way around? Look for patients, screen all patients for caries, then look for the OME.
I see. Okay. Basically, I'm coming from ENT. Yeah, so yeah, most of my patients, we are dealing with children with hearing issues, and then we noticed that there were few studies was reported saying that there is a close relationship between otitis media effusion and also ECC. So hence, we feel like in Malaysia so far there's none of such study was being done. So I feel like I should start from our ENT side. Yeah. So when I examine those patients with this complaint, then at the same time I will try to detect whether there is a presence of ECC or not. Yeah. And yeah, true enough, from our study, there was a close relationship between these two childhood diseases.
So how would you make the clinical recommendation? You now find that if the patient has OME, more patients have caries. How will you then implement this in your clinical practice?
Okay, so since there's a close association between these two, so I would suggest that when patient comes to our clinic, we have to look at the patient as a whole. So not only checking the ears, we should have a quick look over the oral cavity. Yeah. So if there is a presence of caries, then we will make an early referral to the dental team.
Okay. I just foresee that because caries is so common, I'm worried that this is a very incidental finding. Did you do the stats? Did you calculate if you have otitis media, what are the odds of you having caries? And also it sort of doesn't make sense now because caries causes OME, not the other way around, right? So it's sort of like, it becomes a bit confusing in terms of trying to interpret the results. That's just my take on it, Chen Lily. I hope you understand where I'm coming from.
Yeah.
Okay. Okay. Never mind. I have no further comments. Thank you.
Thanks, Prof. Adiza. Prof. Sabarul, any comments or questions?
Dr. Chin, my question will be, you know that dental screening among school children is a routine thing, but the screening for hearing loss, not sure. Is it routine in our country?
It is not routine. It is not routine, but it is not routine. But however, sometimes in the KKM, we do have some programs whereby the ENT team will go to the school and will check on the patients. I mean the children, but it's not a routine. It's not a routine assessment. So most of the time, these children will be coming to our clinic when the parents detected there is some sort of speech delay or hearing impairment. Yeah. So I guess
I'm looking at the purpose of the study. You're actually looking at otitis media, which causes hearing loss. Then you try to correlate with ECC. So the thing is, when a certain patient you have more than 50% of this patient who has multiple medical problems like eczema, all those things. So basically, the main root cause is medical problem, socioeconomic status. Then after that, then they will have otitis media, caries, dietary, they are underweight, all those things. So when you correlate OM with caries, you know you are at the below. That's why it comes together. The cause is more further up. You know, socioeconomic status, knowledge of parents, all those things, medical problems. So it's up, but you're looking at the lower part. I think I'm echoing what Aniza is trying to say. Okay.
Okay, thank you, Prof. Sabarul. Thanks, Prof. Aniza and Dr. Chin Lili.
Thank you so much.
Okay, we are going to proceed with the next presentation. So the next presentation will be by Dr. Teh Kai Jun. Dr. Teh Kai Jun will present her paper on psychological interventions for different topic, sorry, my bad, on associations between patient-reported outcome of dysphagia and penetration aspiration scale among post-radiated nasopharyngeal carcinoma patients. So can we please play the video for abstract C20?
A very good morning to honorable judges, organizing committee and the participants of 24th Medical and Health Research Week 2022. I am Dr. Tay Kai Jun, who is the presenter for oral poster C20 with the title of Association between Patient-Reported Outcome of Dysphagia and Penetration Aspiration Scale among Post-Radiated Nasopharyngeal Carcinoma patients. For the introduction, swallowing dysfunction remains a prime concern among post-radiated nasopharyngeal carcinoma (NPC) patients. Identifying a comprehensive measure of dysphagia is challenging due to the complexity of swallowing physiology. For the objective of our study, it is to investigate the association between patient-reported outcome (PRO) of dysphagia and penetration aspiration scale (PAS, as well as the effects of dysphagia and aspiration on the quality of life (QOL) among post-radiated nasopharyngeal carcinoma patients. For the methods of the study, it is a cross-sectional study which was conducted at a single tertiary center, UKMMC, from June 2019 to July 2020. Post-radiated NPC patients who fulfilled inclusion and exclusion criteria were recruited into our study. The dysphagia PRO was evaluated using the score of DESDC, which is acronym for drinking, eating, swallowing difficulties, and coughing when eating or drinking, and MD Anderson Dysphagia Inventory MDADI questionnaire. MDADI is a self-administered, psychometrically validated questionnaire to evaluate dysphagia-specific quality of life for head and neck cancer patients. It consists of 20 items with 4 subscales, including global, physical, emotional, and functional, with the total score of 100. It ranges from the score of 20 to 100 according to the Likert scale for each item, and higher MDADI score means higher functioning. Fiber optic endoscopic evaluation of swallowing assessment was performed and PAS scores were documented. For the results of our study, total 60 post-irradiated NPC patients were recruited. Out of these 60 patients, 23 patients, which consists of 38.3%, show penetration or aspiration using PAS scale. Swallowing difficulties were the most concerning disability reported from the score of DESDC, which consists of 67% of the patients. However, only those who experience cough during eating or drinking show a significant association with PAS, with the p-value of 0.046 as shown at the table below. The swallowing dysfunction had affected quality of life physically, MDADI-P, the most, with the mean score of 60.0 plus minus 14.5, but it did not notably affect their emotion, MDADI-E, with the mean score of 74.4 plus minus 11.8, or social function, MDADI-F, with the mean score of 78.0 plus minus 14. MDADI composite MDADI-C score, which is combination of physical, functional, and emotional subscales, with the score of less than 60, suggestive of moderate to severe swallowing dysfunction. There is a significant association between MDADI-C score and PAS, with the p-value less than 0.001 was observed. Overall, the correlation between PRO of dysphagia and PAS was poor. For the discussion, some patients who reported at least one symptom to suggest swallowing dysfunction may show no clinical evidence to support it. Ironically, some who demonstrated obvious laryngeal penetration or aspiration did not express it as a swallowing problem. Thus, patients' awareness of swallowing function represents an important aspect of functional recovery after the treatment. An outpatient screening of swallowing difficulties using validated questionnaires may induce the need for clinical evaluation to rule out penetration or aspiration. As a conclusion, the screening of dysphagia is beneficial in raising individual awareness and reducing physicians' tolerance in evaluating the risk of aspiration. The combination of both subjective perceptions of dysphagia and objective evaluation of aspiration is recommended for post-irradiated MPC patients. And here are the references for my study. And thank you so much for the attention.
Thank you, Dr. Teh Kaijun. So maybe we start the question and answer session with Prof. Sabarul.
Okay. Thank you, Dr. Teh. Okay, inside your presentation, you are talking about these complication of radiation in terms of swallowing, penetration, those things. I didn't recall you telling me it's a post-radiation. When is the duration that you do this questionnaire? Is it important?
Yes, it's important. Our inclusion criteria is the patient receive radiotherapy at least 6 months prior to our recruitment to exclude the acute toxicity. And the patient has completed the radiotherapy and follow-up under our clinic.
Okay.
And we would like to exclude all the possible causes for dysphagia, such as stroke, neurodegenerative disease, and exclude all this before we recruit the patient.
So, based on your study also, you show that there is the numbers are quite significant in terms of this aspiration, penetration, or aspiration with the score, and you 60 as the margin. Is it? Is that the standard?
Yeah. Yes.
The scoring of your MDAI. Yeah, and
yes, it is being this MD Anderson dysphagia inventory.
MD Anderson, dysphagia.
Yeah. Yes. This questionnaire. The question is being widely used in the head and neck cancer patients, and previously there is one study that do this to show the significant score. So they use the 60 as the demarcation score to show the swallowing dysfunction. That's why I quote the previous study and use the 60 as the score.
Okay. So based on that thing, how will it change your clinical practice?
Clinical impact. Okay. Yes. So previously, of course, dysphagia is a known complication for post-irradiated nasopharyngeal carcinoma.
Yeah,
but
even
for our sorry?
Even orthopedic surgeon knows that.
Yes. Yeah. But during our surveillance for nasopharyngeal carcinoma, we always have the priority on the recurrence tumor recurrence. Then we do ask on question of dysphagia, but we do not specifically do a fiber optic assessment of the swallowing during our surveillance every month, but we do endoscopic scope to look for tumor recurrence. So this study actually enhance the awareness and actually remind us to should routinely check on this part, and also should do a FIS for the patient that we think that is high risk for aspiration.
Okay. So what you're saying is you are recommending once you put the scope inside the nose, just extend it lower down.
Yeah, you can do a flexible scope to look at the laryngeal inlet and look for penetration and aspiration. Okay. As some of the study actually show 50% of the patient having silent expiration.
Yeah, but this is functional. Is it visible on scope?
Yeah, it's visible.
It's a functional thing. Dysphagia is functional. If you do a scope, can you see it?
The evidence of aspiration, we have to use like in this case, we do a special dye. We do a methylene blue dye to see the color and going into the aspiration. But it's a very simple and fast procedure.
I think I let Aniza continue with my.
Yeah.
I'm an Yeah, you talk about screw everything. I'm okay.
Betul. I think Prof. I echo what Prof. Sabarul is saying because your study says you just want to see dysphagia and aspiration. So the result indicate that you can use this questionnaires as a screening for aspiration. Am I right? That's what I'm getting from your result.
We are trying to find the association whether it can actually lead to, but the correlation is poor from our study. We can only show that with the poor score, it could show a higher risk of aspiration, but we cannot show a significant correlation.
So I think that's what Prof. Sabaru is trying to ask. I mean, do you really need that for screening when we can already see it on the scope? So the answer, saya jawabkan pula, the answer would be, fees, not everybody can do, not everybody is well versed with it. So that's why you want to do this use this questionnaire to see if patient can aspirate. Is that what you're trying to say?
Yes, and another thing is another objective of our study is to investigate the quality of life. So this question actually can show functional and emotional sub-skills, which will tell us about the quality of life of the patient.
Okay, thank you, Kaijun.
Thank you, Prof. Aniza. Thank you.
Thank you, Prof. Sabarul, Prof. Aniza, and Dr. Teh Kaijun. So we will move to the next presentation. The next presenter will be Dr. Nur Iwana binti Abdul Taib. She'll be presenting abstract C21. The topic is psychological interventions for frontliners in a Malaysian teaching hospital, a brief narrative report. So can we have the video for C21?
Good day, fellow judges. I'm Dr. Nur Iwana from the Psychiatry Department. I would like to present my poster of our narrative review titled Psychological Interventions for Frontliners in a Malaysian Teaching Hospital, a brief narrative report. Due to the COVID-19 pandemic, our hospital, Hospital Chancellor Tuanku Muhriz, HCTM, became one of the main hospitals for treating COVID-19 patients in Malaysia. During this time, our staff had to be redeployed to COVID ward, and there were lack of manpower when staff were quarantined when they had COVID-19. All these factors actually led to an increase in psychological stress among other healthcare staff. Considering the need for psychological support by the frontliners, the Psychiatry Department of CTM initiated multiple mental health programs during the MCO period. Thus, our narrative review aimed to describe these different psychological interventions and evaluate the effects of relaxation technique sessions to mitigate the psychological impact of the recent COVID outbreak on medical professionals and healthcare workers, such as doctors, nurses, allied healthcare worker, lab technicians in UKM Medical Center. Since April 2020, the Psychiatry Department of HCTM released 3 digital mental health initiatives, a hotline, and an outreach program. These initiatives were the Psychological Support Guide electronic booklet, which were developed in Malay, called Panduan Sokongan Psychology, a website portal, www.taba.my, a chatbot called IRIS, an acronym for the Illness, Recovery and Self-Management, which the user can find in www.taba.my/iris. There's a psychological first aid PFA hotline, and lastly, an outreach program for the emergency department and operation room staff. During this outreach program, the participants were evaluated using Kessler Psychological Distress Scale, K10, and the Mindful Attention Awareness Scale, MAS questionnaires, before and after the intervention. Our outreach program ran from mid-April until the end of May 2020. The program were dedicated to provide relaxation sessions for staff in the COVID-19 operation room and emergency department, where it was assumed that this department had the highest level of stress at that time. The team will go to the respective department twice a week to lead a 15 to 20-minute relaxation session. Among the 61 participants, most of the respondents were females. aged 30 to 39 years old and were medical staff by profession. So our survey found that the mask score improved after the program, with matched pre and post-test samples showed the relaxation technique sessions had statistically significant increase in mask scores, where median post-test mask score was 48 compared to 4.1 in the pre-test. The psychological first aid hotline was started in early April 2020 for 2 months to support our staff who became PUI or positive COVID-19. Volunteers among the psychiatric department staff will actively call the affected staff and provide PFA as needed. The PFA was done via phone and video calls. Traditionally, PFA should be given face-to-face, but due to the limitation in physical interaction during the COVID pandemic, all these sessions, PFA, were done through telemedicine, teleconsultation. Up to 12 June 2020, we had a total of 16 clients for the PFA hotlines. The Iris chatbot were launched in early May 2020, aimed to provide stress management skills to the public. The chatbot guides user and provides related materials such as audio-visual guide for relaxation techniques and sleep hygiene. The application were made free. The application were made available free for the public. Our website, Tabah.my, were launched early April 2020 for the hospital staff. It provides important information that can help to reduce the burden and distress among the staff, such as links to download the self-help kit e-booklet, helplines for staff to contact when they are in distress, and information on available childcare assistance that can be utilized by the staff, as we noticed that childcare were a big problem for our staff during the MCO period. The electronic booklet were developed and distributed to the public in early April 2020. It was developed in Malay language to cater the need and the lack of these psychological support guides in Malay language, as most of these guides were developed in English language. Our e-booklet consists of 4 chapters and help kits on stress management, relaxation techniques, info on fighting stigma in relation to COVID-19, which was rampant at that time, and psychological first aid. So from the initiatives and our surveys, it was suggested that from this study that our hospital staff appreciated mindfulness better after the outreach session. The pandemic provides an opportunity to explore the use of digital technology to further expand our mental health outreach initiatives. However, further studies will be required to properly analyze the effectiveness of these interventions and services. So that's all for me. Thank you so much.
Thank you, Dr. Nirwana Abdul Talib. So maybe I invite Prof. Aniza to start with the question and answer.
Okay. Thank you, Pramoda. Okay, morning, Iwana.
Morning, Prof.
Yeah, I think you're doing very important work here, taking care of the frontliners, making sure that they're taken care of. And I'm sure just by showing that we care, they already feel better.
So hopefully.
Yeah. So I can see that this is a very brief study. Okay. What do you think is the limitation of your current way of collecting the data for the mindfulness now, and how would you improve in the future?
All right. At that time, when we did the survey during our intervention, the limitation was actually our limitation in number of participants and the willingness actually to do the pre and post test. That's why the number is quite low, because we understand at that time it was early COVID era. It's just at that time when at the peak of the outbreak, so everyone was so busy, everything was unsure. So it was quite difficult to get a proper a proper cohort for us to follow up in order to get a good sample size for the study. That's why the number is quite low.
Okay, for me, it's not just the numbers, it's that there's no control. So it's
Yes.
very hard to come to a conclusion that it's actually your book and your intervention that's giving them the improvement. So that would be one way. But why did you really need to do it in the first place? Because I mean, the intervention is a very good one already. What other data do you hope to collect from this study?
Okay, we were actually doing there were two outcomes that we were hoping to get. Number one is the reduction in distress through K10. Number two is actually the awareness of mindfulness, because in psychiatry, the appreciation of mindfulness actually helps in order to gain the relaxation state when you work and then whatever you do. So, however, in our study, the K10 actually did not show any significant differences. That's why I did not put it there, unfortunately. But mindfulness awareness was better. So we hope actually that this gives us some a baseline result where we can actually explore, does this kind of intervention help our frontliners during the very hectic state of work to improve the awareness towards mindfulness level lah.
Okay, thank you. No further questions from me.
Right, thank you, Prof.
Okay, so Assalamualaikum, Dr. Noriwana. First of all, congratulations to the Department of Psychiatry for having a lot of program, especially when our hospital and also our nation is facing this pandemic. So my question is, you have a lot of program going on, and among all these program, one of the things that I noticed Malaysian are not forthcoming. Kan? That's the nature of Malaysian. Among all these programs, which one do you think is the most effective in terms of trying to achieve what you are want to achieve?
Okay, in terms of effectiveness, because we did not actually measure the whole program's effectiveness, but from our experience, actually the hotline through calling and also the chatbot actually was quite popular during the high state of pandemic, because it actually the chatbot, they can actually just do it whenever they have the time without personal touch. But if they need, we give it us. So, however, we did not actually assess the proper effectiveness of these programs, but hopefully in the future we can do it, because the chatbot is still running, actually, it's still active. So, if Prof want to try, boleh.
Participation, which one is paling active? Ramai orang participate. Which one?
So far the chatbot yang banyak.
Very good. That's
Cuma
good.
I tak ingat the current number lah. But up until
Because
now,
your hotline cuma 16 orang je.
Yeah, memang when we had the number of
And
number
your
of
outreach
staff,
program, the outreach program is a proactive program kan? The outreach program is proactive. You are looking for the participant.
Yeah, we actively search. Yeah.
So I think in terms of if you want to write something, because your presentation is very heterogeneous, you know? Banyak. So if you find a chatbot is the most, maybe you focus on chatbots and focus on that. Then you can go for more objective punya assessment outcome. Also, chatbot is I find that very interesting, especially now. People suka like to chat kan?
Yeah.
And they want to remain anonymous.
Yes.
Right?
Yeah.
Okay. Because later on, if any other intervention, I think you should go towards chatbots.
Yeah, telemedicine style, digital marketing punya style.
Yes. Okay. I find that the findings very interesting. You mentioned that, but your presentation is too heterogeneous.
Yeah. All right.
So heterogeneous semua. So focus lebih mudah lah.
All right.
Okay. Anyway, congratulations to the Department of Psychiatry and to you.
Thank you so much, Prof.
Well done.
Thank you. Well done, Dr. Ivana. So we'll move on. This will be the 9th presenter for today, and the 2 more presentations, inshallah, will soon finish. So the next presentation is by Dr. Wee Xiao Hui. Dr. Wee Xiao Hui is from Department of Ophthalmology. So he will be presenting abstract C24 titled The Perceptions of Eye Healthcare Professionals Towards Glaucoma Screening in Malaysia, a Qualitative Study. So can we have the video for C24?
Good morning to all judges and audience. My name is Wee Xiao Hui. I am a PhD student from Department of Ophthalmology, Faculty of Medicine, UCAM. Today I'm going to present my e-poster titled The Perception of Healthcare Professionals Towards Glaucoma Screening in Malaysia, a Qualitative Study. This is my poster. I'm going to present it section by section. Introduction. Glaucoma is a progressive optic neuropathy which causes irreversible blindness. It affects quality of life of the patient. Glaucoma is difficult to identify since it's asymptomatic. The study reported that most of the elderly patients in Ireland were not aware that they have glaucoma. Glaucoma screening is crucial for detecting glaucoma early before it leads to blindness. The objective of our study is to explore the perception of healthcare professionals on glaucoma screening. Methods. We conducted semi-structured interviews face-to-face while Zoom video platform or at the Ophthalmology Clinic, University Kebangsaan Malaysia Medical Center using a topic guide. This topic guide was created based on literature review and discussion with the research team. 19 interviews were conducted in either English or Malay, with 4 ophthalmologists, 6 optometrists, 5 nurses, 3 ophthalmic technicians, and 1 assistant medical officer. We used purposive sampling to recruit the participants, while snowball sampling was used to recruit the ophthalmic technician. The inclusion criteria are registered eye healthcare professional, fluent English or Malay, and willing to take part in the interview. All of the interviews were recorded, transcribed, and analyzed. The interview in Malay was translated to English, and all interviews were analyzed using Everywall software. We used thematic analysis to analyze the transcript. Results. For the thematic analysis, 3 major themes emerged. The first theme is perceived importance of glaucoma screening. The second theme is current practice of glaucoma screening, and the last theme is barriers towards glaucoma screening. For the first theme, perceived the importance of glaucoma screening, all participants expressed the importance of glaucoma screening in Malaysia. All of them feel that glaucoma screening is important. It is because glaucoma screening can detect the glaucoma earlier so that the patient will not go blind. For the second theme, current practice glaucoma screening, in Malaysia, there are 2 types of glaucoma screening, which are opportunistic case finding and community-based eye screening. So for this picture, opportunistic case finding happens when the patient go to the clinic with a complaint, and at the time of examination, they are found to have glaucoma. And community eye screening happens when an NGO, just as Rotary Club, goes to the rural area to conduct an eye screening program. Okay. And for the third theme, barriers towards glaucoma screening, from the perspective of the eye healthcare professional, there are 3 barriers, which are poor public awareness of glaucoma, perceived lack of trained primary eye care providers, and lack of standardized guidelines for glaucoma screening. Okay, discussion. All the participants expressed the importance of glaucoma screening. So the participants' positive attitude towards glaucoma screening is very important, so that they will educate the public about the importance of glaucoma screening. So that they will encourage the public to attend the eye screening. US Preventative Service Task Force do not recommend population screening for glaucoma in adults. They express that there is no harm or benefits in doing population screening for glaucoma in asymptomatic adults. However, they recommend opportunistic case finding for glaucoma screening. Opportunistic case finding is a better approach for glaucoma screening in developed countries. For the result, there are 3 barriers towards glaucoma screening, which are poor public awareness of glaucoma, lack of trained eye care providers, and lack of guidelines. Poor attendance of glaucoma leads to poor attendance of eye screening. Therefore, the public should be educated on glaucoma awareness so that they will attend the eye screening more often. Trained eye care providers will recover for an effective glaucoma screening program. This is important so that the eye care providers can detect glaucoma and refer the patient to get treatment earlier. Ministry of Health Malaysia published and clinical practice guidelines for management of glaucoma for eye care providers in 2017. However, it has insufficient dissemination to private optometrists. Therefore, most of the private optometrists are not aware of the guidelines. In conclusion, eye healthcare professionals reported a positive attitude towards glaucoma screening in Malaysia. The findings indicated several key themes that can be used to develop a glaucoma screening program in Malaysia. We would like to thank all participants for their participation in this study, and this is the references. Thank you for listening to my presentation. Thank you.
Thank you, Wizia Hui. So I would like to invite Prof. Aniza to start the question and answer session.
Hi, Zhang Hui. Okay, thank you for that presentation. So, can I just clarify? What is you want to look at glaucoma screening? Okay, so why is it important for you to look into the perception of the healthcare worker in order to do this?
Actually, it's like this. Actually, this one is only a part of the result. I have another result. It's more on the focus on the component of glaucoma screening. So that's the reason why I need to seek opinion from the eye healthcare professionals on glaucoma screening. This one is not included in the abstract, the component of glaucoma screening.
Okay. This is mostly qualitative study, am I right? Just
yes.
see
Part of my studies is include the one part of the study is a qualitative study.
Okay, and then how will you use this data? What is the end result? What's the for the whole of your study? What would be the end result that you are hoping for?
Okay, it says like this. This one, it says a part of my study is about teleglaucoma. So before I need to develop a teleglaucoma platform, I need to know the component of the glaucoma screening. So I did a qualitative study, interview with the eye healthcare professionals about glaucoma screening. It's only to get the knowledge about glaucoma screening, component of a glaucoma screening.
Okay, thank you. Nothing further from me.
Prof. Sabarul, anything from you?
Okay. The American screening suggested more of opportunistic care screening as compared to public screening. So Malaysian, we are doing which one? Both.
Actually, we're doing mix both. But mostly I'm more towards opportunistic studies, more towards for provincial eye screening, they're mostly targeted study targeted screening means they're more targeted towards the rural area. But mostly in Malaysia are opportunistic case finding.
So meaning when they have eyesight problem, everything, they come, did the test, and you found out they have glaucoma.
Yeah, it's like when they go to the optometry practice, they have represent with the power problem, but actually it's a glaucoma or any other eye disease that is called opportunistic case finding.
Yeah, okay. Because my interpretation or what I gather from your study is, glaucoma, it's an important thing, especially if you ask everyone who's related with eye healthcare profession. You interviewed 19 healthcare providers. Half of them are ophthalmologists or optometrists.
Yeah, correct.
And you have another half which are nurses, ophthalmologic technician, all those things. So I think without doing a study also, they would agree that screening is important.
Yeah, correct.
You ask any bone-related physician like orthopedics, they will say osteoporosis is important. So targeted group will say it is significant. So I'm not sure the impact. You are looking very superficial, Yeah, when you want to do things, you more in depth.
More to the public, is it?
Either you go to public, what are the problem? Let's say they are late with glaucoma. What was the obstacle? Because the awareness is not there. You're going to people who are professional who knows about glaucoma. So definitely they will be
bias towards
supportive of this initiative. But it's good also that you look into what are the problems at the moment. So maybe you focus on that thing to improve. What is your next step? Maybe you can tell me what's your next phase. You said you are two component of your study. What's the other part of your study?
Actually, it's actually from this study and from this qualitative study, I'm going to know about the component coma screening to develop a telecalcoma platform and also to train the eye care professionals providers for glaucoma screening. So the next phase actually I now is in the stage of going to train the eye care providers on the glaucoma screening.
And you will see the effectiveness of that training of the.
I already
So this is like introduction of your. So you make a thesis. This is very introductory of your.
Yeah, this one actually is the first phase actually.
Okay. So I wish you luck, best of luck in your further studies and your research. Yeah. Okay, thank you.
Thank you.
Thank you, Wiziahu. May you graduate on time, inshallah. Okay, thank you. We'll move on to the last presentation of the day. So the last speaker will be Dr. Wan Awatif Wan Muhammad Zohdi. So Dr. Wan Awatif Wan Muhammad Zohdi will be presenting abstract C31 titled Venous Thromboembolism at Diagnosis in Lymphoma Patients. So can we show the video?
Assalamualaikum and good day. I'm Awatif from Hematology Unit. I would like to present to you our project on the topic of venous thromboembolism at diagnosis in lymphoma patients. Have you ever thought, what is the venous thromboembolism burden among lymphoma patients in Malaysia? What are the patient's characteristics? Which lymphoma characteristics that predispose our newly diagnosed lymphoma to develop VTE? Venous thromboembolism is the leading cause of death in patients with cancer, regardless of cancer stage. Cancer is associated with a hypercoagulable state and a fourfold increase in thrombosis risk. Thrombotic complications in hematologic malignancies have important detrimental clinical implications. It can cause patients' morbidity, mortality, and impacts patients' quality of life. Lymphoma patients are at increased risk of thromboembolic events. However, thromboprophylaxis in these patients is largely underused. This is because antithrombotic prophylaxis is associated with increased hemorrhagic risk and implies additional treatment costs. Hence, clinicians seldomly prescribe it to their patients. It is fundamental to determine which populations could receive a true benefit from thromboprophylaxis. Our study is to determine the rate of venous thromboembolism and to explore the clinical pathological characteristics among newly diagnosed lymphoma patients in a single tertiary level hospital in Kuala Lumpur. This cross-sectional study involved newly diagnosed lymphoma patients who are being referred to Hematology Unit HCTM from April 2021 to May 2022. Patients with solid organ malignancy or relapsed lymphoma are being excluded from our study. The development of VTE is related to various factors, including patient's characteristics and disease status. Hence, patient's age, their performance status, type of lymphoma, serum LDH, presence of the B symptoms, size of the tumor, stage of the disease were obtained at diagnosis. The increment of serum LDH is a relatively non-specific phenomenon. However, it has been recognized as a tumor marker as it reflects tumor burden and high cellular turnover. B symptoms are defined as patient having fever, night sweats, and unintentional weight loss. VTE was defined as any case of pulmonary embolism or deep vein thrombosis detected by imaging. This is our preliminary results. 78 consecutive adult patients with lymphoma were recruited for our study. 10 out of 78 patients, which was 12.8%, in this study had incidental or symptomatic VTE at diagnosis. The median age of patients was 51 years, ranging from 16 to 86 years old. In this study, the following risk factors such as patient's age, performance status, stage of the disease, serum LDH, presence of B symptom and bulky of the disease were identified as VTE risk factor for lymphoma. However, so far, only serum LDH and B symptoms were significantly associated with VTE event, with a p-value of 0.006 and 0.037 respectively. What are the characteristics among our VTE patients? Most of the patients, 70%, had a good performance status. They have ECOG 0 to 1, meaning that they are fully active, able to carry on all pre-disease performance without restriction. 90% of the patients had advanced stage 3 to 4. 100% had increment of serum LDH. 80% presence of the B symptoms. In 60%, they had a bulky disease. The commonest locations that patient had VTE was mediastinal region, which was consist of 30%. Diffuse large B-cell lymphoma was the most prevalent subtype, followed by primary mediastinal B-cell lymphoma, which was 30%, and low-grade B-cell lymphoma only 10%. In conclusion, our study's rate of incidental or symptomatic VTE among newly diagnosed lymphoma patients was 12.8%. Patients with VTE had clinical pathological features reflecting high tumor burden, which include high-grade lymphoma, B symptoms, advanced stage, increment of serum LDH, and bulky disease. These preliminary findings may help clinicians identify the risk factors for VTE in newly diagnosed lymphoma patients in our local setting who may benefit from thromboprophylaxis. These findings need to be confirmed in a larger cohort of patients. With that, I thank you.
Thank you, Dr. Wan Awatif. So I would like to invite questions. Maybe we can start with Prof. Sabarul.
Okay, yeah. Thank you, Dr. Wan Awatif, sorry, unique name. Okay, well done. These are things that we usually want to know, also in orthopedic, the incidence of deep venous thrombosis. One of the things that I would like to know, VTE is defined as case of pulmonary embolism or deep vein thrombosis. So how many among your cases, the one with VTE, the 10 patient out of 78 actually developed pulmonary embolism?
So far, I didn't include in the slide, but the 30% of them developed pulmonary embolism, and 69.
Okay, let me clear your data. You screen 78 patient, kan? You have 78 patient inside your study. Out of the 78, 10 patient ada deep vein thrombosis.
Yes.
Kan? 68 tak ada. Okay, so out of the 10, berapa orang yang ada pulmonary embolism?
Oh, among around 3 of them.
3?
3 of them.
Or 3 daripada 10 ada pulmonary embolism. Okay, and your study have shown that so based on your study, what is the changes in terms of your management in patient with this lymphoma? I think kalau 10% is, we also know 10% will have pulmonary embolism. So based on your study, is there any changes in terms of treating pulmonary deep vein thrombosis?
So basically,
10% is a number that we expected.
Yes. So at this moment, during our clinical practice, we didn't properly screen which patient they are prone to develop VTE. So with this study, we hope that with our findings, we hope that the clinician can take note of these characteristics of the disease and the patients, so that we can start to apply in our daily clinical practice which patient are suitable to
to get DVT prophylaxis, VTE prophylaxis. So because at this moment we don't have any proper score or proper guideline to really apply in our daily clinical practice.
Okay, so my next question is, based on your data, what are the red flag signs which you suspect a patient should be more, you are more concerned of them to develop a deep vein thrombosis, based on your data?
Okay, especially those patients we have a high tumor burden, those who are having a very high and markedly high serum LDH, and then that's number one. Number two, a bulky disease, especially the size of tumor more than 10 centimeter, and number three, the location of the tumor. So far that I have seen, patient, the tumor located in mediastinal region, and also CNS are prone to get.
That's not reflected in your result. Your result shows that patient with serum LDH yang tinggi dan juga B symptoms are the two main red flag for you to be more high suspicious of deep vein thrombosis. Now, based on your result, you have two red flags.
Yes. I forgot to include including the B symptoms. Also, one of the factors that patient can have high prone to get VTE. However, when we see a patient, we have to see as a whole. Some of them they have B symptoms, but the serum LDH is not really high. The tumor burden is also not that high, and the size of tumor also not that big. So you have to see a patient as a whole, and we see the patient whether is it an advanced stage or is just some indolent lymphoma only.
Yeah. Okay. Aniza.
Okay. Thank you, Prof. So I applaud you and your research group for trying to do this, because with incidence of 12%, I mean, cost effectively in terms of medicine, you can't go around screening everybody with lymphoma for DVT. Hence why you need to do this study to know who do we need to screen. And it's a very tricky study because there are a lot of confounders and other contributing factors of DVT. So maybe can I ask, did you also take into account these other confounders like obesity or mobilization, use of drugs that may affect the formation of DVT in your study?
Thank you, Prof. Actually, this is a prelim study. Yes, I did include the BMI, including a patient's mobilization and also type of chemotherapy. So actually, this is a prospective study. So I will look in a 1 year time how the patients progress, including their ECOG status and also their type of chemotherapy, and including the screening and all. Basically, we have a follow-up of patients during surveillance, including scan. So that time we can pick up any patient that can develop VTA as well, because it's a prospective study.
Yeah, I think there's still a lot more work that needs to be done for this. And I wish you all the best of luck, and I hope that you are able to come up with a guideline to help clinicians screen the patients who need screening. Okay, thank you.
Thank you, Prof.
Thank you, Dr. Wan Awatif, and thank you, Prof. Aniza and Prof. Sabarul for the comments. So I think that wraps up the presentation for the module H, which is the clinical poster presentation for the 24th Medical and Health Research Week. So on behalf of the Scientific Committee of the 24th Medical Health and Research Week, I would like to congratulate all the participants for sending out their abstracts, and then after that submitting the posters as well as the pre-recorded videos. It's a lot of task, and I know it's challenging since you all work in the clinical departments, kan, in the midst of wards and clinics and your busy schedule, you still manage to submit on time. And congratulations for being able to complete your research milestones and having it to submit and present it today in the panel of judges. So we will choose 3 winners from the presenters today, and the winners of the poster presentation competition will be announced in the website of SPI Fakulti Perubatan UKM, and we expect to announce the winners by 2 days, and hopefully, and you will also receive emails to say that you have won the poster competition. Apart from that, all abstracts that is submitted to the 24th Medical and Health Research Week will be presented in the medical and health journal as a supplement in accordance with the research week that we have annually. So last but not least, I would like to thank our panel of judges, Professor Sabarul as well as Prof. Aniza, for spending their precious 2.5 hours for deliberating on all the presentations that we have today. And we've got a total of 10 presentations. They must be very tired. And for the participants and the postgraduate students participating in the 24th Medical and Health Research Week, I hope you all have learned from the presentation today. And indeed, we have gathered a lot of new ideas, and you can see how all these researches is actually translating into how we improve clinical practice for our patients. So we are doing this treating research as a way how we can improve patient care later on. So with that, I would like to thank all of you, and I would like to conclude Module H session for 24th Medical and Health Research Week. Thank you, everyone. So I hope the judges, I'll open a breakout room so that we can deliberate the results. Thank you. Zaki, saya tak boleh assign diri saya. Zaki boleh assign diri saya masuk dalam breakout room?
Boleh, Prof. Sekejap ya. Ha? Sekejap.
Okay.
Okay, betul.